When Brian said he put the talk together, I previewed his slides, and here was the first slide. So I said, well, that doesn't show any bias at all. So I said, Brian, that's not going to work. You need to modify it.
What's wrong with it?
I said, Brian, that's not going to work. We have to show some maturity, so I'll modify it. All right, so as we say in a lot of our talks, just talking about general topics on joint replacements, we have disclaimers. And one is the information that we provide here are really just generalizations, okay? We try to tailor specifics to patients when we're with the patient themselves, but when you're talking to a big audience, everybody has a little different problem. Everybody's problem may respond a little differently to surgery. So these are going to be just generalizations, okay? So we really do, when you come in to talk to a joint surgeon before surgery, we really tailor our preoperative talk specifically to your problem. But in a talk like this with so many people, again, these are just generalizations. So we're going to talk a little bit about arthritis today. We're also going to talk about the treatment of arthritis. Arthritis is a big deal. It's the #1 cause of disability in the United States today. There are at least 66 million Americans who know they have arthritis and are living with it, and probably another 23 million who have it that we haven't seen yet that know they have the problem. So somebody in Philadelphia actually put a name on this with all the baby boomers coming in with their arthritis. They call this boomeritis, which is not a bad term. Now, just looking at how many joint replacements we're doing today, we're doing about, in this country, just in the United States, we're doing about 500,000 knee replacements and about 300,000 hip replacements. Now, by the year 2030, with all the baby boomers coming through and all the arthritis, people wearing out, that number on the knees is going to increase by over 600%, going up to about 3.5 million, and it's going to increase by about 300% for hip replacements. So what you see, the red line, let me see if I can, the red line is the increase in the joint replacements that's going to happen in the next 15 years. And the blue line are the surgeons that are adequately trained to do those joint replacements. So we're going to have a huge access problem on our hands in the future if we don't figure out some way to train more joint replacements like we do here at OrthoCarolina. We actually have a fellowship where we train orthopedic surgeons that have finished their residency. They're board eligible to be an orthopedic surgeon, but they come and spend an extra year with us learning the specific techniques to go out and do joint replacements in the future the right way. And these are the things we're trying to do to make sure that everybody here is able to be taken care of at the right time. Now, the other thing we do that sort of separates us from a lot of the other individuals is we do a lot of research at OrthoCarolina. We actually have an OrthoCarolina Research Institute. OCRI is what we call it, O-C-R-I. And that's a big thing. We put out more hip and knee research than just about anybody in the country at this point for the last several years. Right now, we have 28 FDA clinical studies going on. We have over 80 scientific research projects going on where we do clinical follow-up on patients and how they're doing. Unless you follow your patients, you don't know what you're doing right, and you certainly don't know what you're doing wrong and what you could do better. So you have to follow these patients and research them. Our research, we monitor about 6,000 study patients annually, and we have over 20 articles written and published in scientific journals every year. And that's a lot of work, and it's a big deal, and I take my hat off to our research institute. We have 10 researchers that do nothing but OrthoCarolina research. Now, to start off the program, I'm going to first just ask a generic question. I'm going to ask Dr. Springer, Dr. Sheff, a generic question. What is arthritis, Neil?
So, in general, I think the way to explain this in simple terms is between the two ends of a bone in a joint, you've got cartilage, which is sort of the intervening tissue that allows the two sides of a bone to actually articulate or kind of go through a range of motion smoothly. And in general, when you have arthritis, you have damage to that cartilage or that intervening smooth surface. When you look at it specifically, in Greek, arthro means joint, itis means inflammation, so you have inflammation of the joint. There's several conditions out there that can cause damage to that cartilage, and most of the common forms that we see are osteoarthritis, which you may have been told at some point that you have, or rheumatoid arthritis, which is more of an inflammatory disorder that your body is almost attacking that cartilage and damaging it from the inside. Other things that we can see arthritis from is infection in the joint. Some people have gout or pseudo-gout where they have crystals that are deposited in the joint that, again, cause inflammation and destruction of that cartilage over time. This is the most common form that we see, which is osteoarthritis. Again, it's more wear and tear arthritis. And again, it's that cushion between the two edges of the bone, that white shiny cartilage that you normally see is what gets destroyed in arthritis.
Can everybody hear okay?
No.
All right, so Neil, speak up just a little bit.
Sure.
All right, I think this slide speaks for itself.
There's a lot of different reasons why you can get arthritis, though.
It's for the web. This was for the webcam.
So some of the reasons that are listed here, sometimes you can injure your joint sometime before, and as a result, over time, you develop arthritis or damage to that cartilage. Being overweight or being obese definitely does cause you to put more stress across your joints and potentially wear out the cartilage a little earlier. There's some disorders from genetics that may also predispose you to getting arthritis early. If you have some people come in saying that their legs look they're a little more knock-kneed or a little more bow-legged. Again, so alignment of your extremity can potentially also lead to arthritis. And there's some reasons that we don't know of why people get it.
Neil, what's rheumatoid arthritis? I mean, I know osteoarthritis, people wear out their joints, wear and tear is what people commonly say, but so many people think they have rheumatoid arthritis. Talk to us about that.
Yeah, so rheumatoid arthritis usually it's an inflammatory disorder where, again, your body winds up attacking its own cartilage, and that's how you wind up destroying the cartilage in your joints. We don't see people with rheumatoid arthritis as often now with completely destroyed joints because we have very good medications from the rheumatology side of things where they can actually modify the disease process. But again, most times the people who do have rheumatoid arthritis come in complaining of multiple joints that hurt. They may have a lot more swelling, and that's chronic, that doesn't change, that may be there for a long period of time. And they usually are under the care of the rheumatologist that gives them medications, either by mouth or injections, and there's a whole host of new different medications out there for rheumatoid arthritis. But most people who do have it usually know they have it because they've been under the care of a primary care doctor for some time.
How do they diagnose it, Neil?
Usually it's by blood work. You can go in, there's different markers in your blood that will tell us that you have high levels of inflammatory markers that tell us that you have rheumatoid arthritis. And again, I think the other thing is there's a lot of different factors, but one of the things, again, is most people come in complaining of multiple joints that bother them. It's not just one single joint.
All right, so I have Neil on a roll right now, so I'm going to keep asking a few questions. Neil, somebody thinks they have arthritis. What are the symptoms that somebody may have when they have common forms of arthritis?
Yeah, so most of the time that people come in with pain in that joint, most of the time it's activity related. So maybe when you're walking, if you're running, if you're doing some type of activity. A lot of people complain of pain when they're sitting for long periods of time and they stand up from a seated position. When you're talking about arthritis in the hip, they have difficulty putting on their shoes and their socks. They can't bend forward. So certain activities that you normally do on a regular basis may be affected by arthritis. The other things that we look at, again, swelling, I think more common in rheumatoid arthritis, but again, you can see that sometimes, even if you have just a low level of arthritis in your joint, you may get swelling because you've just tweaked the joint for whatever reason. It's very common. We see patients in the office that have arthritis in their knee. They don't even know they have it. And they were walking this weekend. They twisted their knee, stepping off of a curb. They come in with a large fluid collection in their knee, and their knee is really swollen. You get an x-ray, and they've got arthritis. And what they've done is basically inflamed their knee over that weekend, which eventually goes away sometimes. And then over time, like we were talking about, especially for knees, you can become more knock-kneed or more bow-legged. And the more common thing is to become more bow-legged over time. And so those are the things that really, I think, show up as symptoms that something's wrong with your joint.
All right, and then Neil, you're seeing somebody for the first time in the office. They come in, and what are you going to do to diagnose their problem? What should they expect from you?
Yeah. So in general, if you come in, say, with a painful knee for the first time, the first thing we would do is get some x-rays. We'd like to have these x-rays while you're weight bearing to give us an idea of what your knee looks like when it's under stress. The other thing is that we'll do an exam. We'll get a good sense of if you do have a lot of inflammation in the joint or a lot of swelling, a lot of fluid in your knee. That gives us an idea of what's going on inside the joint. Number two, we look at the overall alignment of your extremity to get a sense. Are you bow-legged? Are you knock-kneed? Is that giving us some indication that something's going on? And the other thing that we look at is we'll look at your range of motion. Over time, you also may get stiff. Most people with arthritis also complain of pain in the back of their knee. and it's because some of the tissue behind the back of the knee gets a little stiff and contracted over time. So giving you a range of motion will give us an idea. And the other thing we check is stability. The ligaments around the knee that keep your knee stable, that allow you to walk and do your activities of daily living, we make sure that none of those ligaments have not stretched out or have become incompetent over time.
All right, and by the way, at the end of the session, we're going to have a little question and answer period. We'll have plenty of time, so just write any questions you have down, and at the end of the session, we'll go through questions also. I'm going to let Dr. Sheth catch his breath for a minute. I've sort of worn him out here, but I want to ask Dr. Springer, Brian, what do you look at when you look at an x-ray? People come in for an x-ray. What's normal? What's abnormal? What are we talking about? Let's start with the knee.
I think the best way to determine what or understand what an arthritic knee looks like on x-ray is to look at what a normal knee looks like and compare them side by side. And that's what we have in this slide here. And as Dr. Sheth was saying, most of the time arthritis is really an x-ray diagnosis. We do it based on your history, your symptoms, and x-rays. So you don't necessarily need expensive MRIs and CAT scans to diagnose arthritis. Most of the time we can do it with relatively straightforward tests and just asking you questions and you tell us what our symptoms are. So if you look at the x-ray on your left, that is a normal knee from the front. And an important thing that we do at our office is we take an x-ray of you with your knee standing up. Because what we want to see is what your knee looks like when you're putting your weight on it, and not so much what it looks like when you're lying down and there's no stress on it. So oftentimes you'll see when we have patients come into the office and they've had x-rays from outside, oftentimes we'll repeat them so we can get a good sense of what their x-ray looks like when they're standing up and not lying flat down on the table. So if you look at the x-ray on the left, the first thing you'll notice when you compare it to the one on the right is that nice smooth space that's in between there. It looks like air, or you're seeing black in between the two ends of the bones. But really what that is that's the cushion in between the two ends of the bones. And cushion is cartilage, right? So cartilage is a good thing. That's what you want to see. Because cartilage isn't bone, it doesn't show up on an x-ray. Only bone shows up on an x-ray. And so that space that's in between there actually represents the thickness of the cartilage that's on the ends of those two bones. So a plain x-ray gives us a good idea of the quantity of the cartilage. It may not necessarily always give us a good idea of the quality of the cartilage or how good it is. If you compare that x-ray on the left to the one on the right, you see a couple different things. The most notable thing that you see is that that space, particularly on the inside portion of the knee, is gone. And you've heard people use the term, and maybe you've even used it yourself, called bone against bone arthritis. Literally, that means that cartilage space in between the two ends of the bones has worn away, and when you walk, you're just rubbing bone against bone. Interestingly enough, cartilage in the knee doesn't have any nerve fibers in it, so that's why you don't feel walking on your knee with a normal, healthy knee. But that bone that sits right underneath of the cartilage is very rich in nerve fibers. And once that cartilage wears away and those bones start hitting each other, you really start to see an increase in your pain. The other thing that you'll notice is the deformity or the malalignment of the knee. So you look at that knee on your right compared to the one on your left, that person's bow-legged, or what we call varus deformity. And that's because of the abnormal wear of the cartilage on the inside of the knee. Imagine if you jacked that space open on the medial side of the knee, it would look more like this. So the alignment or the bow-leggedness is a result of the wear pattern of the arthritis. And then the third thing I'll point out is bone spurs, or what we call osteophytes. And you'll see those forming around the periphery of the joint. And what a bone spur is it's your body's response to stress. We know that a knee can't regenerate cartilage. Unfortunately, once that cartilage is gone, it's gone. Your body is very good at regenerating bone. You think about broken bones and things like that, how well it heals them. So when that cartilage wears away and the stress in your knee goes up, your body does the best thing it knows how to do to fight that, and it lays down bone around the periphery of the knee joint. And that's what bone spurs are. So we always explain to people that bone spurs are a secondary feature of arthritis. If you went in this knee and just took out the bone spurs, you can see it wouldn't really help you out very much, because every time you stood up and walked, you'd still be rubbing bone against bone. We see a very similar pattern in the hip. The hip joint's a ball and socket joint. Okay, so you look at the normal x-ray on your left, and you see the nice round ball and the nice round socket. And again, you see that space in between there, just like you did in the knee. That space is the cushion or the cartilage. And now you compare that to the x-ray on the right, and you see very similar findings. The space is gone, so you see the bone against bone arthritis, number one. And then you see the bone spurs or the osteophytes lining around the periphery of that joint because of the increased stress or pain, or because of the increased stress, excuse me, from the loss of the cartilage in the joint.
So Brian, when someone has this process going on, so this is one hip, and their other hip looks like this, are their legs uneven? Do they feel like one's shorter than the other?
Typically, most of the time, people will feel the arthritic hip is shorter. And the reason that it's shorter is not that the bone length is any different, because the bones are still the same length, but you've lost that spacer in between there. Okay, so you used to be like this with the nice cushion, but now over time that hip joint is worn into that socket, and so you've lost that spacer in between the ball and the socket. There's a lot of other factors that play into leg length, tilt in your spine. Some people do actually have differences in the length of your legs. But in general, most people, as their arthritic hip wears, they will feel that leg get shorter. But it's a slow process that happens over time, so some patients may not necessarily even notice that there's a difference in the length of their legs.
So Brian, someone comes into your office and they have this x-ray. Do they have to have surgery?
Well, the decision to have a joint replacement is really, there's a lot of factors that go into it. And what we always tell patients is that we don't operate on x-rays, we operate on patients. And so occasionally we'll see a patient with a worn out arthritic hip, but their symptoms are relatively mild. They're still able to do a lot of the things that they want to do. They're still able to get around during the day, not compromise their normal lifestyle. And just because their arthritis is bad on the x-ray, we don't necessarily tell them that they have to have a joint replacement. The important thing to remember about joint replacement surgery is that it's an elective surgery. And it's important that you look at all the options that are available to treat it. Historically, we used to say that joint replacement surgery is absolutely the last resort. And we can talk about that maybe in the discussion because our thinking on that has changed a little bit. But the important part is just because you have a diagnosis of arthritis, it doesn't mean automatically that you have to have a joint replacement. And there are several other treatment options that we're going to talk about here that are conservative options to think about before you make the decision to have a joint replacement.
Brian, why don't you just keep
Sure.
talking just a little bit about the more conservative measures, and then we'll get back to Neil.
So this is just a list of some of the options that are available, and you can see it's a pretty wide list. Some of you guys have probably heard about a lot of these things. Everything from acetaminophen, which is Tylenol, which is kind of the very first line type of medicine that's over the counter that you may take occasionally for mild to moderate symptoms of early arthritis. As we talked about before and alluded to in some of the earlier slides, weight loss and exercise are probably two of the most important things that you can think about. And if you look at most of the studies and the research that's done on arthritis, and you look at all of these treatments, the two things that stand out for slowing progression of arthritis are weight loss and exercise. People think, and there's a misconception out there, that once you're diagnosed with arthritis, you can't exercise, you have to become sedentary, you're going to wear out your joint faster. And that actually couldn't be further from the truth. When you have an arthritic joint, you need to find an exercise that works for you, either under the guise of a therapist or your doctor. Find something that you can do comfortably, something that allows you to maintain the motion in the joint, but more importantly, everybody thinks of arthritis as just being a bone condition, and we forget about the soft tissues and the muscles and the tendons and the ligaments and how they're affected by the arthritic process as well. So maintaining your motion and your strength around the joint are very important as well. And that's where we get into the issue of lifestyle change. You may not be able to go out and run 2 miles anymore, but you might be able to get on a stationary bike, or you might be able to go to a water aerobics class where you're not pounding on your joint all the time and be able to maintain the motion and build up your strength in your knee joint. occasionally we'll recommend the use of an assisted device, a cane, a walker, etc., and certain aids that we have to help with dressing and things like that for people that tend to be a little bit more debilitated. Medications, again, there's a whole long list. Tylenol, as I said, first line defense. Remember, Tylenol is a mild pain reliever and a fever reducer. It's not an anti-inflammation medicine. Okay, so it does help with mild pain. But if you look at some of the other medicines, what we call the NSAIDs, or the non-steroidal anti-inflammatories, things that are over the counter like ibuprofen and naproxen, and some of the prescription medicines like Celebrex, those are more specifically designed to treat inflammation in the joint. But as Walt mentioned before, you have to take that into context with your medical history, with other medications that you take. You always have to be a little bit careful with your stomach and issues that you can potentially get if you overtake these types of medicines. So these are not medicines that are harmless or things that you should take in direction with your physician.
Now, Brian, I hear that, at least in our literature, when you take a step when you're walking, you put up to 3 to 4 times your weight with every step you take. And the way I broach that with patients is every 10 pounds you lose, that's like losing 30 to 40 pounds for the joint, right, which can make a tremendous difference. When you run, actually, you're up to 10 to 12 times your body weight across joints, so it's a big deal.
There's a lot of information and a lot of misinformation that's out there about supplements. And the important thing to remember about supplements is that they're not regulated through our Food and Drug Administration the way a normal medication or a prescription medication is, or even a lot of over-the-counter medications are regulated by the FDA. So the FDA doesn't have a lot of control about the type or the substance of what's in these medications. And I always go back to a study that was done at the University of Maryland in their pharmacy school. It's probably been about 15 years ago, where they took about the 10 top brands of glucosamine and chondroitin sulfate, and they tested all of them. And a certain percentage of them had no glucosamine in them at all, or very trace amounts of it. Again, no regulation or oversight by the FDA, so you have to be careful. So if you look at a medicine, a very popular medicine like glucosamine, and you read the bottle and it says, wow, it's going to regenerate my cartilage, that's pretty good. Well, we know that does not happen. It seems a little bit out of the ordinary to be able to take a pill and somehow it's going to get to the joint and regenerate that cartilage. I'm glad it doesn't, we'd be out of business.
Yeah.
However, if you look at some of the properties of this medicine, the best way that I describe it for patients is it probably has some anti-inflammatory properties. It may or may not act a little bit like a vitamin for the healthy cartilage that you still have. It's pretty clear that it's not going to regenerate cartilage. And we don't have a lot of scientific evidence in some of the major studies that have been done to show that it's doing what it says it's doing. However, there may actually be a decent placebo effect for this medicine, which I think is fine. It has very little side effects, unless you're allergic to shellfish, which it can have a reaction to that. And it's a little bit on the pricey side for some of these over-the-counter medicines. So the bottom line is we don't have a lot of direct scientific evidence to say that these make a big difference in modifying the disease process.
So at least a lot of the names we give to this total group are called nutraceuticals, nutrients that are supplements, and we just call them nutraceuticals. Brian, any downside, Neil, any downside to these nutraceuticals?
I don't think so. I mean, people ask about this a lot, and what I tell them is that we know that it's not going to hurt you, but I can't tell you that it's going to help you. It probably costs about $17 a month to get glucosamine, chondroitin sulfate over the counter, and if people are willing to try it, that's fine. I do have some patients who swear by it and say that when they've got off of it, their pain has gotten worse. So I think there's no downside to trying it. But again, I can't tell you 100% that it's going to help you.
All right, so the other common thing that you've had or somebody you know have had it, they've had injections into their joints. Neil, let's talk just for a minute about injections. What are we injecting? Why do we inject? When do we inject? And who do we inject? Did you get all that?
Right. So in general, we look at two different types of injections that someone may offer you, that we may talk to you about in the office. The first type of injection is a cortisone injection or a steroid injection. Typically, we add to this some numbing medication, which usually takes effect probably 15 or 20 minutes after you leave the office, the day you get the injection. And then the other portion is the steroid component, which probably kicks in about 1 to 2 days after having the injection. The other type of injection is something called viscosupplementation, or it's kind of like the glucosamine chondroitin sulfate stuff that you take by mouth, but it's an injectable form. And this is usually a series of 3 injections given once a week for 3 weeks. So when are you a candidate for or either one of these injections? In general, I think all of us will use these viscosupplementation injections when you have very mild arthritis. But before that, we usually give 1 cortisone injection at least to see if that works. And the reason that we give the cortisone injection is the steroid component is like giving you a high-dose anti-inflammatory, like Advil or Aleve or Motrin, right in your knee. It doesn't go anywhere else in your body. It usually stays contained within the joint. In general, we use these injections for knees much more commonly than hips. The hip injections I don't think last as long. It's hard to do in the office sometimes. And the knee injection is much easier to do for us, and I think we can reproducibly do it for a lot of patients.
Neil, why do they call these rooster injections? Everybody's here has heard of the rooster injection.
Yeah,
As a matter of fact, here's Dr. Mason chasing a rooster right outside of our clinic.
So the injection Dr. Bieber's talking about is this viscosupplementation or this hyaluronic acid injection, the one that you get once a week for 3 weeks. And it's made from the rooster comb. And so as a result, like that actually has the components that will give the sort of the nutrients that you can give for your cartilage and help lubricate the joint.
All right, and Neil, if you could just touch on alternative medicine, acupuncture, biofeedback, deep tissue massage.
A lot of people do come in talking about acupuncture or acupressure or deep tissue massage and different sort of even chiropractic care for arthritis, and people ask us questions about that. Again, I think it's one of those things that some people have probably some bit of a placebo effect with some of these therapies, and some people swear by them and it works for them, and if it works for you, that's great. And if it doesn't work for you, we can offer you some other alternatives. Again, I don't discourage anyone from doing any of these things if this is what they really think that is going to help them. But again, I can't tell you 100% without good scientific evidence whether it will help you or not.
All right, so Brian, our question we hear every day in the office when we diagnose arthritis is, when should I have my joint replaced? Is it when you need a car payment, or when we have an open? I mean, when is it? I mean, there's so much talked about as far as not that you have arthritis, but when do we do the surgery?
Right, and that's a really hard question for us alone as physicians to answer. And I think a lot of patients want us to tell them that they need to have a joint replacement. And I think that's a little bit of the wrong way to go about doing it. I think what I tell patients is this needs to be a team decision, not only between myself and the patient, but between your family. Because as we talked about before, this is an elective surgery. And what is as important as deciding to have it done is also deciding when to have it done, and also deciding what your support network is going to be around the time that you have surgery. I mentioned this earlier when one of the old sayings that we used to have was wait absolutely as long as you can before you have joint replacement. And I suspect 20 years ago, Walt, you're in practice 20 years ago. Or 30 years ago. I suspect that was a pretty common thing that was said to patients. You're too young. You have a lot of other options. Wait. And in a sense, that's changed a little bit. It's changed as the surgeries have gotten better, the recovery's gotten faster. The implants that we use are better and more durable. But the other thing that we found is there is such a thing as waiting too long. And this can be different for different people, but the way that I explain this to people is, let's just say after you have surgery, you want to reach this functional level right here. And right now you're about here. So you have this much to make up after you have surgery. Pretty reasonable. But some people are concerned about joint replacement, they're worried about it, they've heard myths or concerns, and so they wait 5 years, and now they wait 10 years. And now they have this much of a gap to make up. And a lot of the studies would show they can never get back up to that level that they wanted to. That maybe they can get back to where they were 5 years or 10 years ago, but maybe not all the way to where they wanted to be when they initially thought about having it done. And again, that's different for every patient. Everybody's level of recovery and where they want to be is going to be different depending on what your lifestyle is. But some of the things that we hear people say is, do you have pain that stops you from doing the things that you like to do every day? This isn't the surgery for the patient that comes in and says, hey doc, I used to be able to run 10 miles, I can only run 5, I want my knee replaced so I can run 10 again. That's not the kind of patient that gets a joint replacement. This is, I have pain every day, pain that stops me from doing the things that I like to do, whether it's housework, spending time with your family, pain that may interrupt how you sleep, and pain that has failed some of the conservative treatments that we talked about earlier. So you've tried the injections, the shots, things like that, and they just don't seem to get you where you want to be. I explain this to patients more than anything. This is a lifestyle surgery. It's not a bionic surgery. This isn't to get you back to do things that you've never been able to do before. This type of surgery is to give you your lifestyle back that you had before you started having pain from your arthritis.
All right, we're going to switch to Neil. Brian, you hurt me. Golly. All right, so we're getting ready to do a joint replacement. You're sitting in our office, and your first question is going to be, how does this work? What is it? How does it work? Neil, how does a joint replacement work?
So if you look at the top, let's talk about hip replacements first. If you look at that top row going across, you can see that x-ray on the way left. You can see how the cartilage is no longer there. There's no space. And like Brian showed before, there are those bone spurs. And so basically this is a very severely arthritic hip. That is a picture in the middle on the top of a hip replacement. And what we've done there is we have cut off the head of the femur, or the ball part of the ball and socket joint. Okay? And what we've done is we've put a metal shell that has a surface on the back of it that the bone likes to grow into on the inside part of the pelvis there. So we've basically put a socket on the inside part of the pelvis, and we've put a stem on the inside part of your bone. So that stem on that x-ray is actually inside your bone. Again, on the top part of that stem that's inside the bone, there is a surface that the bone likes to grow into. So typically, in the United States, we don't use cement to glue in components for hip replacements. In between, you have a ball and a little plastic liner that we've put in. So basically, when originally you had bone, cartilage, bone for your joint, now the cartilage is destroyed, so now you're bone on bone. And we've replaced that now with essentially metal, plastic, and metal as your new surface. And so it's not as good as your bone, cartilage, bone that you were born with, but it's better than having bone on bone. When you look at knee replacements, it's sort of a similar type of theory. If you look at the x-ray on the way left, you can see kind of looks like that x-ray we showed before, where there is no space there on the inside part of the joint, and you've got some bone spurs all the way around. The middle part is a picture of a knee replacement, and essentially what we do is we cut off the diseased cartilage and bone on the end of your thigh bone and the top of your shin bone, and we essentially glue those components in, so it's almost like capping a tooth. Then we put a fancy piece of plastic in between to basically give you metal, plastic, and metal as that articulation where, again, you had bone, cartilage, bone before, and now the cartilage has been destroyed.
Great. Okay. Should I be able to choose the type of joint replacement I want? Brian?
This is, I think, and you guys would probably agree, that the internet is a tremendous source of information, and the internet is a tremendous source of misinformation as well. And it's very difficult for patients to sort out what is good information and what is bad information. And we're also in an era now with what we call direct-to-consumer marketing, where whether it's a pharmaceutical company, whether it's an implant company, are able to market implants directly to consumers or patients. And I personally think that that is a very difficult thing to do. I personally think it's a very unfair thing for companies to do. In a sense, it's good because it piques interest and it raises questions and it raises awareness. But it's very difficult in a 30-second commercial for someone to be able to say, yes, that's the medication I want to take. Yes, that's the type of implant that I want to take. And so we see all kinds of advertisements like Jack Nicklaus and Mary Lou Retton and Jimmy Connors, who are paid spokespeople for these companies, touting the benefits of these different types of implants. And if you just type in, this is probably a couple months old now, but if you just type in joint replacement to Google in a search, you get almost 11 million sites that come up. I don't know how as a patient you can possibly filter through that information and get out of that what you need to get out of that. And at the end, we're going to put up a couple websites that are very informational and non-biased. But you see a lot of information on there. For example, several years ago, there was a very popular thing called a unispacer, which was just a little metal shim that got put into that area that was bone against bone. Seemed like a great idea. Well, I can tell you the majority of them failed within a year, and those patients ended up needing to have joint replacements, and they're now off the market. This particular type of implant in your upper left-hand corner is now off the market. It was called a deuce knee replacement. It came on the market about 2 years ago. It's already been taken off of the market because of some complications. And we see a lot of misinformation about recovery, about incision sizes, about buzzwords like minimally invasive surgery and all these types of different things. And so it's a very dangerous place. I think the important part of this is, and this is something that you guys have heard probably quite a bit about. If you open any newspaper or watch any TV for more than an hour, you're probably going to see an ad from a law firm talking about some types of hip replacement recently that has been recalled. I can tell you, if we sat in this room 5 years ago and gave you this seminar, several of us would have sat here and said that this type of hip replacement is a very good type of implant, we think, for young, active patients. And now look what we see. This has been recalled because of high failure rates. Okay? So a lot of these types of newer implants have been pushed through the market, have been pushed through the FDA relatively quickly, and we're starting to see a lot of failures. So I tell patients a couple things. If you're going to spend your time researching and look at 11 million sites on the internet, spend your time choosing your surgeon. Trust your surgeon, know your surgeon, and let your surgeon choose the implants that are right for you rather than you choosing the type of implants that you want. Can you back up
Sure.
one slide? I just want to see. There's no question when you look at complications and success after joint replacement that they are directly tied to the number that the surgeon does and the number that the hospital does. And it makes sense. You think about anything in life, if you do a lot of them, you're going to be better at them. If you're used to taking care of them, you're going to be better at them. There's going to be less complications. An interesting fact that you may not know is that about 70% of joint replacements in this country, some would argue even 80%, are done by surgeons that do less than 25 a year. Less than 25 a year. Just by way of looking at our group, so you know, is that Dr. Beaver discussed earlier what a fellowship-trained joint replacement surgeon is. So a fellowship-trained joint replacement surgeon is someone who has spent extra time in their training learning nothing but hip and knee replacement. And there are 9 of us in our group that do nothing but joint replacement. No other surgeries, no shoulder, no elbow, no hand, no foot and ankle, so you're out of luck if you have any of those, problems. But on average, we do about 2,500 joint replacements a year. This hospital had the #1 volume for joint replacements in North Carolina this year. So the nurses, the staff, the protocols are very much in tune with taking care of patients that have hip and knee problems. I tell my patients, I know if you're going to have surgery at this hospital that you're going to be in an operating room that only does joint replacements, that you're going to be on a floor where there's only joint replacement patients. And there's no intermingling of sick hospital patients with our joint replacement patient population. And that makes a big difference when you start talking about infection risks and things like that. And the other important thing is the hospitals in our group have established programs and protocols for patients that have joint replacements to get them through from beginning to end. And the other important thing is that you know, the United States is one of the only industrialized countries in the world that does not have what we call a joint registry. Every major country in the world follows their patients' implants from the time that it's put in till they die or failure. And so every year countries like England and Wales and Australia put out reports on success of different types of implants, how well they've done, etc. And so we look a lot towards that information. The United States has nothing like that. We're working towards it, and hopefully we're in soon to be able to do that. One of our other partners, Tom Faring, had the insight when he started practicing here 20 years ago, Walt, is that right? Probably?
Just a little over 20.
A little over 20 years ago, that he was going to start a registry at OrthoCarolina. And so we track every single patient in our hip and knee center that has an implant put in. If some of you have had them, you've been into our office, you know, you fill out the little questionnaires that ask you about how your joint replacement is doing. We now have about 18,000 joint replacements in our registry that we track, and it helps us keep track of success, implants, failures where we need to keep track of. That implant registry is second only to the Mayo Clinic's registry in the country for keeping track of implants.
So the last registry, national registry, was in New Zealand, and maybe 8 to 10 years ago, if you look at where joints were done in New Zealand, they were done in almost every hospital in New Zealand. And as they started the joint registry, it's a public registry. People could get on and see where successful joint replacements were done, where revision joint replacements were done, where their joints were failing, and little by little, over a 10-year period of time, now you see most of the joints done in New Zealand are in the major medical centers where they do a lot of them. So it does make a tremendous difference, and we look forward to having a national joint registry in this country. All right, Neil, a couple of your patients here.
Yeah.
What can or can't a patient do after a joint replacement?
This is a very important question. I think that the biggest thing that I think we do when talking to patients in the office is trying to gauge what your expectation is after joint replacement. And I think the best way to have the best outcome after having a total hip or a total knee replacement is to really be realistic about your expectation, understand what you can and cannot do. I think you have to have a very frank discussion with your surgeon to say what they will allow you and not allow you to do. There's a whole list of things that Dr. Beaver has put up here that we allow patients to do after hip and knee replacements. And again, it also depends on how much function you have beforehand and where you're coming from. So a 45-year-old male who wants to have a knee replacement and has arthritis because they had an injury to the knee before 20 years ago is going to be different than someone who's maybe potentially 80 years old and is very sedentary, is not very active, and needs a knee replacement for the same type of arthritis. So I think the bottom line really is to try to get a sense of what your expectations are, what your surgeon's expectations are, and the closer you can make those two, the better you will have a better chance you'll have of having a good outcome after your joint replacement.
And I'll just key in on what Dr. Sheth was saying. One of the most unhappy patients you could have in your practice when they come in is a patient that, number one, had very little arthritis and had a knee or hip replacement done for the wrong reasons, because they don't get better. They were actually pretty good to start with, and this doesn't make them better. Or another is a patient that just didn't understand the expectations of what to expect after surgery. So those are very, very important things. Now, I want to just finish this, and then we're going to go to question and answer session. What's the best thing I can do to prepare myself for a joint replacement? What can you do to prepare yourself for a joint replacement? And Dr. Springer, you want to just comment on a few websites?
We've kind of touched on this all along, but it's a relatively simple answer that has a lot of implications to it. And the best thing that you can do to prepare yourself is educate yourself. We talked about educating yourself about your surgeon. We talked about the concerns about educating yourself about through the internet and the type of implants that you want. But spend the time and ask your doctor questions. Come in prepared to ask them questions. Learn as much about it as you can. My philosophy is the more you know going into this, Number one, the less apprehension that you're going to have, because everybody's going to be apprehensive around the time of surgery, no matter what, no matter how comfortable you feel. But the more you know, the more questions that you have answered before you go into the surgery, the better you're going to feel and the more you're going to know what to expect. There is no way that any of us up here can tell you exactly what it's going to be like to go through a joint replacement. We draw on our experiences from our other patients. You draw on experiences from people that you know that have joint replacement, but everybody is completely different. The more you understand about the procedure, the hospitals offer teaching classes on joint replacement to go to ahead of time. These websites here have good, unbiased information about joint replacement and recovery. The most important is it says here, ask your doctor questions so that you can understand it.
And with that, I wanted to introduce Dr. Tom Fehring. He's our senior partner that's been working a little later than he should today. We're glad to have him here. Dr. Fehring's probably put out more hip and knee research by himself than most everybody else in the country, and he's a great resource for questions. And at this point, I'd like to open up the floor for questions. Yes, sir.
My wife has been diagnosed with osteoarthritis. Can you tell me a little bit about that?
Dr. Fehring.
Sure. Osteonecrosis is loss of the blood supply to the femoral head. So that's the top of your femur bone, the ball. Normally it's perfectly round. In avascular necrosis, it collapses and becomes flattened as the bone kind of dies in certain areas. And really the only treatment for that is a hip replacement once it collapses.
No other treatment?
Once it's collapsed, there's no other treatment that's successful.
What if it hadn't collapsed, Tom? We hear a lot about different not chemotherapies, but medications that can possibly help this,
Yeah.
or smaller surgeries.
Right, a couple things that I use, and that's a core decompression, where if the ball is still round, you can drill into the ball and stimulate blood flow in that area. And also I inject marrow products into that to try to stimulate the bone to regenerate. Success rate of that is about 50-50.
Okay. Yes, sir.
You mentioned cortisone injections, and I've been getting them for a long, long time. And they would limit them to once or twice a year per joint or something like that. But recently I've heard physicians say that the studies that say it was the corticosteroids that were creating problems with the bone itself, that actually it was the arthritic process itself that was creating problems, and that now I should not be so concerned about how often I get a cortisone injection.
Okay. Neil, you talked a little bit earlier about injections.
Yeah.
What about getting too many injections?
Yeah, we don't like to give injections probably more than once every 3 to 4 months. And it depends. If you have a patient, say, who's 90 years old, who's very sick, who's got a bad arthritic knee, happy to give an injection every 3 months to keep them comfortable because they're never going to be a candidate for having surgery. If I have a younger patient who has arthritis in their knee, again, we can give them injections once every 4 months or so. And the reason we don't want to give them too often is because I think the steroid will actually cause more damage to the cartilage itself. Once you get into a pattern, if you do have a bad arthritic knee and you're getting injections every 4 months, and they're lasting, in the beginning they were lasting for 4 months, and now they're lasting 3 months, and now they're only lasting for about a week, it's probably time to have a conversation about something else with your surgeon because you probably need something done surgically. But again, the theory was that we don't want to damage the cartilage by giving too many injections over a short period of time.
So a lot of us, when we give injections, we not only just inject a steroid in the knee, but we mix a little Marcaine or lidocaine commonly. And is there any problem with putting lidocaine in an injection? Anybody? Marcaine, lidocaine?
Well, there is some research that says that using additives such as Marcaine and lidocaine, which make you feel better for the first 4 or 5 hours, can actually damage the cartilage cells. So there is a theory that we don't like to give too much of the lidocaine. The steroid is okay by itself.
But the damage that the cortisone does is to the cartilage, not necessarily the bone.
That's correct. Correct.
The chondrocytes, cartilage
Bone
cells.
and bone already.
Right. 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 Correct. You're right. But and if you're bone on bone, a lot of times these shots just don't work. There's no downside to it. So if it's bone on bone, it works for a while. Keep it up. Bob.
Thank you. Based
All right, Dr. Springer, you want to talk about failure rates
Sure.
in knee and hip replacements?
Based on the hardware that's being used today, and we can generalize that to hip and knee replacement, what is the anticipated failure rate of the implants? And that's, that question too has a lot of different answers depending on, number one, what you define as failure. So if you look just purely at the wear of the prosthesis, the parts that rub against each other, because there's no doubt no matter how good our materials are, just purely based on the law of physics, if you rub two parts together, eventually they're gonna wear. So if you look purely just at the wear properties of a joint replacement, either the ball and socket in a hip or the femur and the tibia in the knee, and you take out all other factors, the wear rates with the newer generation materials are extremely low. So if you look at a hip and you look at the ball on the socket and how much will that wear in a year, the estimates range anywhere from 0.01 millimeters per year to 0.1 millimeters per year, depending on the type of materials. And some of the greatest breakthroughs in joint replacement surgery in the past 10 years now have been the evolution of these plastics materials that are much more resistant to wear than what they used to be. Now that's under ideal conditions in a simulator where they just rub the parts against each other and measure wear. So you've heard about things like a 30-year knee replacement that's advertised on TV. That's optimal conditions in a simulator where if someone averages 1 million cycles on their joint replacement a year, they stick it into a simulator and run it for 30 million cycles and take it out and say, yep, looks good, should last 30 years. Well, that's ideal circumstances. And there's a lot of other factors that play into how well or how long the joint replacement will last you. And it's very difficult to tell an individual patient how long yours will last. If you get one, it'll last you 15 years. If you get one, it'll be 18. Yours will be 22. Because there's so many other factors that play into that, including surgical technique, how well the implants are put in, things like that. So is it unreasonable now for a joint replacement to think that it could last 20 years, 25 years? Probably not under ideal circumstances. If you look at failures and you look at early failures, and Tom Faring has done a lot of work on this, some of the most common reasons for early failures of joint replacements are technically related or infection, which is now one of the biggest problems that we're dealing with in joint replacement.
And on that, Dr. Faring, can you talk just for a minute? I know the topic of infection is going to come up, so we'll just head it off right here. Talk a little bit about joint infections, the prevalence, and what we do about it if it happens.
Sure. And the bottom line, just to add to what Brian says, for most people who have a joint replacement, they never need a second one, pretty much regardless of their age. I've been around a little longer, and 20, 25-year results are not terribly uncommon. In terms of infection, that's one of the real bothers, but the infection rates are less than 1%. That means 99% of people never have to deal with this. So while it's a concern, it's not an overriding concern. If you do have an infection, the usual treatment is removal of the implant, where we put in an implant that's a temporary prosthesis that has antibiotics in it, and you go with that for 3 months, and then we reimplant a new one. And then the success rate for that is anywhere between 85 and 95%. So it's less than 1%, and the operation to fix it is almost 90% successful.
So that when you say successful, Tom, you're talking about you've cured the infection.
Correct.
Right. Okay. Yes, sir.
I want to ask, if you have a knee replacement, what's the recovery time required before you can go back to work and start going normal life?
Dr. Sheff?
It's kind of along with the lines of what Dr. Springer said. I think everyone responds differently to total knee replacement surgery. In general, if you've got good support at home, you're in the hospital for about 2 to 3 days. You go home, you usually have a physical therapist that comes out to your house for the first couple of weeks. You come back to the office, we take a look at you at that point, and you probably come back another month later or so, it's about 6 weeks I'd say by 6 weeks, people are feeling pretty good. Pain is resolved for the most part, and your swelling has definitely decreased significantly. But it probably takes 3 to 6 months till you start feeling like, wow, this doesn't really hurt as much anymore. You're kind of moving along and getting about with most of your daily activities of daily living. But again, it's different. Some people fall out to, you know, within 2 or 4 weeks, they feel really good. They feel, wow, this is the best thing ever. And some people take a little bit longer. So again, I think it's, again, matching up your expectation of what you expect after surgery, and getting a good sense of where you're going to fall out in that. So it's a little bit of an individual question. It's hard to predict exactly.
Good. Yes, sir, in the red?
Yes. I was interested in what you were saying about sometimes being of younger age, it's actually better to reach the level that you want to be at. And I've been through the 7 scopes, all of that, but I'm always afraid that if I get replacement, I won't be able to do my job anymore. And if you could just kind of...
What do you do for a living, sir?
I do warehouse work. So I'm on a concrete floor all day long.
So what are the Brian, what are the limitations after joint replacement, after knee replacement and hip replacement? What do you tell your patients?
You know, it's, you're right. I mean, that's a lot of stress on your implants. You're a young guy. And if you're, how old are you if you don't mind me?
52.
You're 52. So the average age of a joint replacement in this country, I think, is about 62 right now, 62, 63, and getting younger, rapidly getting younger. As I said, our implants have gotten better, our techniques have gotten better. But you have to strike, you know, a balance. If the only thing you can't do with your knee is work at your warehouse, then, you know, do you think about, okay, do I need to find a more sedentary job? If you're getting to the point where outside of work is becoming more debilitating for you, your lifestyle is becoming more of a chore, you're not able to do some of the simple things that you enjoy, everything's a trade-off. So if you decide to have a joint replacement at a younger age, what's the risk? The risk is that, well, it may not, you know, last you as long as the guy that's 75 years old. We don't know that for sure. That's just all in theory. That's just all in theory, as Dr. Faring was alluding to earlier. Majority of patients that have joint replacements that are done well and rehabbed well, the materials can last them the rest of your life. But no question there's a trade-off between at what point in time do you say, enough's enough, this stuff's not working, my lifestyle's been compromised enough. I understand that my longevity with a joint replacement could be a little bit less, but you know, you're early 50s now. How are you going to be living with this knee for another 5 to 7 to 8 to 10 years, and what's your quality of life going to be like?
I mean, I wear a brace constantly now.
So, you know, Walt's I think the other part of that question is, what can I do? You know, would I allow you to go back to doing warehouse work with an artificial knee replacement? I would. We don't know what the long-term ramifications are. I tell my patients joint replacement, the only thing I really limit them from doing at this point is repetitive impact, which really is running. I say you can run if someone's chasing you, but other than that, we try and avoid the repetitive impact. We like to think of it as fluid motions with your leg where your foot doesn't necessarily leave the ground and recontact the ground. And we all may do things a little bit different on how much we restrict our patients.
Okay.
Walking is fine.
How about
Absolutely.
playing golf?
Absolutely.
Yes. Absolutely.
Golf okay?
Yeah, that's malpractice to not tell someone they can't play golf. That'll get us in trouble. Now I'm going to go back and forth right now over here.
You've hit on basically a single knee replacement. Let's go into the dual knee replacement territory. I have severe osteoarthritis in one leg and bone on bone in the other. So I'm considering, when that time gets here, a dual knee replacement. What's the recovery time, and do you recommend that, or what are we there with that?
Okay. Well, let me start by saying, how many on the panel do bilateral knee replacements, 2 knee replacements at the same time?
Probably less than 5 a year.
Very rare. And the reason being is there's been a lot of studies done on this, is that the mortality rate and the prevalence of ending up in an ICU, the mortality rate is 1%. So it means 1 out of 100 people die. Okay, and your chance of ending up in an ICU is on the order of 4 or 5% with a bilateral total knee replacement. And that's looking at multiple studies, kind of pooled all the patients to come up with that. In my mind, that's too big a risk. I have bilateral knee arthritis. I'm going to have one at a time. And so I wouldn't recommend anything else that I wouldn't have on myself to my patients.
But Tom,
That's debatable.
but after a bilateral knee replacement, what about rehab? Is it more difficult? Essentially, you don't have a, when I say good leg, you don't have a non-operative leg to stand on. Is that right? It makes it more difficult. Yes, sir.
Just quick aside before my question, I can confirm this gentleman's question on the recovery time. My wife and I are featured for knee replacements within the last 4 to 5 years, and we were both operative within 4 weeks, and I was climbing on an airplane and continuing my job in 6 weeks. So,
Great.
it was different, but it does very help.
I don't remember doing your knee.
We were in Austin, Texas. My question, though, in selecting a surgeon, I'm sure I'm understanding how the training fellowship is working. Are you starting with a class of degreed MDs?
Yes.
And then taking it above in a focused manner?
Well, what a fellowship is when you finished your medical school training, you've done your general surgery internship, you've done your 3 to 4 to 5 years of orthopedic training, so you've graduated from an orthopedic program, and then you go to a joint fellowship for 1 additional year to learn the specifics about joint replacement surgery. So yes, you're an orthopedic surgeon, and on top of that, you've specialized in joint replacements.
Thank you.
Yes, sir. Yes, ma'am, in the back.
And then along that line, those trainees, because I have heard rumors, I have no idea for sure or not, but can they step in and do your surgery?
Well, they can step in and do.
Your doctor that you think is going to be doing it?
No, no, ma'am. The answer is they could go into practice tomorrow if they wanted to, but they're here to learn. They're here to assist. You know, we can't do it by ourselves. You have to have somebody holding, watching, and while they're holding and watching, they're also assisting us while we do the surgery. But we're the surgeons that do the surgery. Yes, ma'am. Good question. Yes, sir?
What is the, I see this coming for me, I don't know how soon, but should I be working with my general practitioner first, or should I go directly to an ortho or some such specialty?
Dr. Sheff?
Most of the time, we do get referrals from a primary care physician because they come in. You may come into your primary care doctor's office and say you have knee pain or hip pain, and they may get an X-ray and diagnose you with osteoarthritis or some type of arthritis, and at that point, they may send you to us to be seen.
Are they generally capable of analyzing an X-ray like that?
It depends on how severe your arthritis is. I think in some of the X-rays that we showed, it was pretty easy to show to you that you have arthritis. If it's a little less severe than that, it might be hard to show, or for them hard for them to pick up because they don't look at X-rays every day. It's okay if your primary care physician will give you anti-inflammatories and treat you conservatively for a while as well, if they're comfortable doing that. And then at some point, if you say, wow, this is really not working, I need to speak to someone who's more of a specialist, that may be the appropriate time for you to come see us.
Mine, I have periods where I can hardly walk, and then I'll go for weeks with no pain at all. How do you analyze that?
It's very typical of arthritis, kind of waxes and wanes. And over time, I think it gets to a point where it gets to be a little more constant, and that's when you come in and say, I might need to have something done.
So in my case, the injections or treatment with medication might be the best.
If you get to a point where, what we don't want to have happen is have you treated for a long period of time where things are getting worse over time, but you're kind of still being treated conservatively. Because the other risk that we worry about is as patients get older, they have a higher risk of falling. And if you have arthritis in your hip or your knee, you're going to have some difficulty with some of the muscles around the joints to keep you stable. And as a result, we don't want you to have a higher risk of falling. So you need to be seen if you're getting to a point where the pain is more constant and you don't think that the treatment that you're getting is really taking care of what your issue is.
Questions? Right, Greg?
drive the decision to select a partial knee replacement versus a full knee replacement? I think I've got that term correct. And then how would that affect knee recovery?
Okay. Brian?
Great question. So the question was, what would drive your decision to do a partial knee replacement versus a full knee replacement? And it is somewhat surgeon dependent, and surgeons' comfort level and outlook on partial knee replacements. But there's also very specific criteria for someone to have a successful partial knee replacement. And so if you think of your knee as divided up into three parts, the inside part or the medial part, the outside part or the lateral part, and the part behind your kneecap, so your knee's really made up of three separate compartments. A partial knee replacement would only replace one of those three parts. Most commonly the medial part or the inside part of the knee. So the success of a partial knee replacement, a lot of it depends on the fact that you have arthritis solely limited to that inside portion of your knee, and the rest of your knee looks normal, and that's somewhat debatable, but the rest of your knee looks normal, that you have well-preserved range of motion or flexibility in your knee, that you don't have too much deformity, and that you have intact ligaments in your knee. And so in our practice, in patients that I see, that may be 1 in 30 knees that I see in the office, 1 out of 30. And it may be different for different surgeons depending on how strict they are with that criteria. So maybe 1 in 30, maybe, I don't know, you guys, you know?
Probably even less. I think,
Yeah.
I think that procedure is very dependent upon who you choose, and it has to be done in the right patient.
So
if you choose the wrong patient, they will not do well with that.
Right. So the other part of that is one is very specific for partial knee, or one is the very specific indications for actually doing a partial knee replacement. And then the second one is the frequency with which it's done. You know, if I only see 1 in every 50 or 60 patients that needs a partial knee replacement, I'm probably not doing a whole lot of them, right? And the converse to that is if you're doing a whole lot of them, you might be pushing the indications a little bit. So it kind of balances itself out a little bit. But I think the bottom line with partial knee replacement is extremely strict indications. Technically a little bit of a harder surgery to do than a full knee replacement, okay? The advantages, maybe a little bit of a quicker recovery early on, maybe a little bit of a more natural feel to your knee because you're only replacing 1 of the 3 parts. Most of the studies would show by about a year that they're probably about equal to each other in the most part. And then you have to factor in all those other technical difficulties, maybe a little bit of a higher failure rate with a partial knee replacement than with a full.
So we have a joint registry. We're able to go back and we're able to pull partial knee replacements that we revised or redone. You know, a lot of these are sent in to us from outside. We do about 700 redo knee and hip replacements here because we're a referral center. And if you look at the redos on the partials, I would say the majority of the ones we do, if you look at the x-rays the patient had before they had a partial, they weren't a good candidate to start with, all right? So they don't do well. And quite a few of the remaining redos were not done correctly because it's a harder operation. But I think if it's done well on the right person, chances are it'll be very successful. Okay, let's go right over here, and then we're going to come down here.
I have a follow-up question on the infection rate. If I understood it correctly, you said it's only 1%.
Less than 1%.
Less than 1%. And then if the person that does have that problem, they have a second surgery, which solves the infection problem, and then a final surgery. Is that correct for the?
Correct. You remove the implant.
And that works for 90% of the people.
85 to 90%.
What becomes of the 10% that it didn't work for?
You do it again. And the results of that are probably about 80% successful. And a lot of this has to do with what we call the host, meaning someone who has no medical problems, right, is healthy, is thin. That's a good host. Someone who's on steroids, has diabetes, is obese, that's a bad host. They don't fight infection as well as someone who's a little healthy. So some of that factors into it.
I wanted to just comment. Dr. Bo Mason just came out of surgery late today, and we're going to field some questions for him. Question on this side of the room. Yes, sir.
What are some of the common challenges that patients have with recovery?
Okay, Dr. Mason, you just finished doing several joint replacements. What are your patients going to have trouble with?
Hip or knee, which way would you go?
Both.
Starting with knees, gaining motion, controlling pain and gaining motion. And those go hand in hand. A lot of times people, when you've had a knee replacement, they will do well in the hospital. They're ready for the sort of the acute pain that you have to go through. But when they get home, they kind of will let off a little bit on the gas sometimes. They get tired of having pain every day. Talking to a number of patients, it's a dull, aching discomfort. It just doesn't want to go away. You do your exercise and it's still stiff afterwards. And that goes on for a longer period of time than a lot of people really anticipate. And they kind of get down and they quit. So you want to make sure that as you do something like, as you go into knee replacement surgery, that you're kind of committed to stay with physical therapy and continue to do that. Hips, I think the bigger, hips tend to recover a good bit faster than knees. And I think there are fewer challenges in terms of a patient recovery from hips. All of these patients are going to be on narcotic pain medications, so constipation's an issue, appetite's an issue, and sleep tends to be an issue.
Okay. There was a question right down here.
Well, a couple of them have been answered, but I have another question regarding if you have to have a hip and a knee replaced, both on the same side, which would you do first?
Okay, so if you need a hip and a knee replacement, both on the same side, and I'll throw this question out, or if they're on opposite sides, which would you do first, the hip or the knee? Brian?
It's a great question. And again, it's individualized for the patient, but the general rule is that you start with your hip first, especially if they're on the same side. And there's several reasons for that. One is a good portion of patients' knee pain, if you have a very arthritic hip, can actually be referred down from your hip. So we will often see patients that have very arthritic hips, and all they complain about is their knee hurting them. And you get an x-ray of their knee and it looks normal. And if you do an exam, you can determine that actually the source of their knee pain is actually from their hip joint. So that's one reason. It can help with referred pain down to your knee. If they're both arthritic, it's actually much easier to rehab your hip replacement if you have an arthritic knee below it than it is to rehab your knee replacement if you have an arthritic hip above it. So in general, we recommend doing the hip replacement first.
Okay, thank you. Let me just, quick question in the very back. What is our time limit here?
6:30.
6:30, okay. Question on this side? Yes, ma'am.
How long is the surgery typically for knee replacement? And if you would just touch on anesthesia and if you ever would consider doing it under more localized than general anesthesia.
Okay. Bo? Mason?
Yeah, generally, the surgeries are around 60 minutes from the time that we actually get started to the time that we're finished with the implanting the materials. Another 15 minutes or so to kind of get things closed up. And there's a good 15 to 30 minutes on either side of that that's setup time. So from the time you kind of leave your loved one to the time you see them again, adding the recovery time is about 3.5 to 4 hours. But the time that they're spending in the operating room is right around 2 hours, or just a little under 2 hours. And then, I'm sorry.
Anesthesia. Just talk briefly on anesthesia.
Commonly, we can do these surgeries under a regional anesthesia. The anesthesiologists look at the statistical risk associated with that, and somebody that has pulmonary disease is more likely to do well with a regional anesthetic. But what we do in addition to help control pain for almost all of our patients is we do some blocks, I don't know if you have talked about that already.
We have not.
Blocks that help control the pain, and those really reduce the sort of that initial 48 hours of discomfort. But yeah, if you have a preference for regional anesthetic,
Yes.
then certainly we can accommodate that.
All right, I want to ask a question because we're going to run out of time in a minute. We're going to have a few more questions here, but Dr. Faring, what are, with hip and knee replacements, what are the more common complications we see, and what do we do to prevent them? I know that's on everybody's mind.
Sure. Well, we've spoken about infection, and you get to prevent that. We hope that you're in good nutritional status. We test for that. We make sure you see your dentist ahead of time. So these are a few of the things that can help before surgery. Intraoperatively, we give you antibiotics. After surgery, we all tend to use occlusive dressings that aren't changed for a week, so we're worried about hospital obtained infections. So we've kind of gotten around that by using occlusive dressings.
What does that
So
mean?
that means a dressing that has a very strong adhesive on it that isn't changed for a week. So nobody messes with it once we put it on in the operating
It's
room.
an antimicrobial barrier in
It has some silver in it, which actually elutes during the week and keeps things clean. The other big concern is blood clots. So infections number one, blood clots in your leg are number two. And I think as a group, we've used blood thinners. We all favor Coumadin. It's had the longest track record. It needs to be monitored by getting some tests on a periodic basis to make sure your blood doesn't get too thin. In that regard, we're trying to prevent what's called a pulmonary embolus, where that clot could go to your lung. That's an extremely rare, but not an unheard of possibility.
Okay. Yes, ma'am, over here. Yeah.
In regarding the hip replacement, how do you determine, I've heard that if you make an incision in the front, the recovery time is faster than the side or the back, because you don't cut through the muscle in the front?
That's a difficult thing. Some surgeons train differently. Surgeon that's trained to go into the back, if they try to go into the front, may not be as successful. A surgeon that's trained to go in the front and he tries to go in the back, may not be as successful. This is one of the things that I think if a hip replacement is well done by an experienced surgeon who does this type of approach all the time, I think it's probably a wash. Now, on the panel, we have people that go in the back of the hip and people that go into the side of the hip and people that go through the front of the hip. So I'm going to tell you, they're going to say that their technique of going in is probably a little bit better than the others. So
We're actually doing a study to try to answer that question right now, which is a prospective randomized study to try to give us some data to say, is one way potentially better than another way? We don't know that answer.
Right. I just read about it, how the recovery was much faster since studying in Texas.
I suspect the person that wrote that article goes through the front.
You have to be careful with what you do. There's a great deal of marketing that goes into a lot of this stuff that's out there.
Yes, sir, in the back, you've had your hand up a while.
As individual surgeons, do you use the same knee apparatus with every patient, or does it vary for some reason from patient to patient? And collectively, within the OrthoCarolina practice, like how many different knee apparatuses might you find?
That's a tough question, so I'm going to turn that over to Dr. Springer.
It is a tough question. If you just look at our panel here, there's probably at least 3 or 4 different types of, we just talk about knees, different types of prosthesis that we all use. My analogy for implants is kind of like golf clubs. And we'll take Dr. Beaver for example. Dr. Beaver is a mediocre golfer. It's just for example. It's just for effect.
Go ahead, Brian. Hurt me again.
If Dr. Beaver took Tiger Woods golf clubs and played a round of golf, he would not be Tiger Woods. If Tiger Woods took Dr. Beaver's golf clubs and played a round of golf, he would still be Tiger Woods and probably still do very well. And so the thing that I tell my patients is that it's not so much in the clubs that you're hitting with, it's in the swing. And you could take any one of the implants that we use, company A through Z, and put them in your knee. As a matter of fact, we could put company A in your right knee and company B in your left knee. And if they were done well technically and you rehabbed it well, you would probably not be able to tell the difference between company A and company B. Now, we use the implants that we use for a variety of different reasons. Our training, a lot of us are involved in implant design with companies, and that's important for patients to know that. And what we all see over time as implants that have stood the test of time. You saw the slide that we showed about a recall of an implant for something that was introduced as new technology that was touted to be the latest and greatest. And what your philosophy really should be is you don't want, it's kind of like a car. You want the car that's been around for a while, but every year there's kind of updates to it, newer models, as opposed to the first company to roll the first car off the assembly line. You don't want to be the guy driving that car. And most of the major implant manufacturers are relatively on par with each other from a technological standpoint, with some minor exceptions. They all tout different bells and whistles, so to speak, because they're now marketing it directly to you. But I think the bottom line is, still gets back to the swing.
And well, first of all, the analogy with tiger stops there. All right. Secondly, is probably for us just as important as putting a knee replacement in that I do. To put a knee replacement in by this company, we also have the instruments that we use to precisely put the knee in. I'm very familiar with the knee instruments I use for my knee replacement. Dr. Fearing uses a different company, and he's not going to be as familiar with this knee instrumentation as his knee instrumentation, so it does make a difference there. All right, yes ma'am, right here. I'm going to try to go to some people we hadn't heard from. How are you non-weight bearing? Yeah, the same day you can be up on it. Right away, you can weight bear to your tolerance, and I'll just quickly answer this one and we'll move on. You can weight bear to your tolerance. Now, the one thing you have to keep in mind, a lot of the newer anesthetic approaches, we're putting what are called femoral nerve blocks up above near the hip to block the nerve, the pain nerve going down to the knee, and that can make your muscles a little bit weak. So yes, you can be up on your knee right away, but you sometimes have to be in an immobilizer just so your knee won't give way with you when you fully weight bear. The other well, we let you start bending right away also. Usually the day of surgery, sometimes people want to rest that day, but the next morning you go into a bending machine, the therapist starts working with you, you get out of bed and start walking. So we really are very aggressive in getting the knee moving, getting you moving, because that helps a lot of things. It helps your lungs to be up and moving so you don't get pneumonia. It helps prevent blood clots because the muscles are working even more. It helps wound healing because of the circulation. So it does a lot of things when you get the knee moving right away. Yes, sir.
I'm actually scheduled for a bilateral TKR in about 3 weeks. And Dr. Fearing's comment, I'm sure, had my wife alarmed and perked my ears up. What's the alternative? What's the time frame if I don't do both at once? How close do you do them back to back?
All right, Dr. Fearing, you've commented on this. They're scared. They're scared to death back there.
It's a controversial area. I mean, if you're a healthy person who has no medical problems and is a good host and has a certain deformity, you might be a reasonable candidate for a bilateral knee replacement. As a general rule, it's more risky. Okay, so I usually will do them 3 months apart, 2 to 3 months apart. You want to give your body time to adapt. The nutritional status has to come back up to par, and that's why we have that gap in between.
Yes, ma'am, right behind him. Yes, ma'am.
Following up on her question, after you have the knee replacement, can you damage it?
Can you damage it after you've had a knee replacement? Dr. Sheth?
Yeah, a lot of people ask that question. The one thing that we do worry about is if you do fall afterwards, you can still break the bone around a knee replacement. That would be a problem that needs to be fixed. But other than that, I mean, that's probably the most common thing that we see with regards to damage to the components. Other than that, usually your activities of daily living and whatever you're going to do activity-wise probably will not damage the actual prosthesis itself, but we do worry about potentially falling and breaking around the knee replacement.
And one of the other things is right after your knee replacement, you know, you're just a day or two, you're still in the hospital, you still have your femoral nerve block. If you were to lose control of the leg without your immobilizer, fall down, bend the knee more than it wants to, you can disrupt the the repaired skin. You can disrupt the repaired entry into the knee, which is right beside the kneecap through a ligament. You can pull all that apart and increase risk of infection if that were to open. And usually you have to return to surgery. So you have to be very careful.
The way that you would most likely injure yourself is to baby your knee. If you, it is unlikely that you're going to suffer a fall. You could fall down without a new knee and hurt yourself. The most likely way that you're going to hurt your new knee is to baby it in the physical therapy afterwards.
All right, question in the very back.
If you have to have both knees replaced and you don't do it at the same time, what is the time frame in between?
What is the time frame between knees? And that's very interesting. We're going to get some different comments. You know, early on, we would say 3 months between is what we like. You've recovered well. You know, your nutritional status is back up. But also, historically speaking, insurance companies wouldn't pay for that second knee until you were 3 months out. So is it arbitrary? Well, it was by the insurance company. And then we found that if you did it too soon, before 3 months, people just weren't quite back in shape to tolerate a second knee. Any other comments from the podium?
There was a very good study looking at about 60,000 patients and looked at Medicare data, and they showed that if you did that second surgery inside 3 months, your risk of infection was nearly double. So that's part of the reason that we did.
So let me ask a question also. We talk about infection, we talk about antibiotics, we talk about a lot of factors that influence patients after surgery. What percentage of the patients you operate on, what percentage of the patients would you say are immunosuppressed? And what makes up an immunosuppressed patient, meaning someone that doesn't have an immune system that is ready to fight infection? Let's just go down. Brian?
I think the actual number of patients whose immune system is compromised is probably actually relatively low, but I think Walt brings up a good point, which is you have the opportunity to correct a lot of these modifiable factors that increase your risk for infection going into surgery. And so we think about obesity being a tremendous cause, and the risk of your infection, your risk of infection goes up tremendously as your weight goes up. Your diabetes and getting your blood sugar under control, your nutritional status and making sure you have good protein nutrition, making sure you stop smoking before surgery. All of those factors are modifiable. There are some things that you can't control. If you have certain types of diseases and you're on certain types of medicines, those are not controllable. But those modifiable risk factors, I think it's important that you understand those and do everything that you can to try and change that. And we're seeing now a lot of patients have a condition that we call metabolic syndrome, where they're overweight, they have high cholesterol, high blood pressure, and diabetes. And if you look at their infection rate, it's tremendous compared to a subgroup of patients that don't have this so-called metabolic patients. So think about things that are modifiable and what you can put your efforts into to change.
Anything else from the podium? Brian covered that pretty well. One thing I would say is recent study out looked at BMI. That's when you take your height and your weight and you come up with a ratio that's called the body mass index. And they showed anybody with a BMI over 40 has a 7 times complication rate from infection with a joint replacement than someone with a BMI under 40. So there are a lot of studies going on, and it is a big deal for us. Yes, ma'am.
You're talking about the modifications. I'm going in for a total knee replacement, but I also have rheumatoid arthritis. So I've been taken off of methotrexate and Orencia prior to having the surgery. Is this going to be something I need to be concerned about as far as infection is concerned?
I think that we stop these, a lot of these drugs. We usually won't stop the steroids if you're on steroids like prednisone beforehand, because you can get into trouble with that. And that is somewhat of a depressant as far as the immune system. But what we worry about more with some of the medications you're talking about is wound healing. And that's why we stop them 3 to 4 weeks, depending on Remicade and some of the other rheumatoid medications. We'll sometimes stop some of these up to 4 to 6 weeks ahead of time and won't start them for 3 or 4 weeks later because of wound healing problems. Yes, sir.
With a total knee replacement, you mentioned about, if you have an ACL damage, do you have to go through that surgery first before they do a knee replacement, or is everything done at the same time?
Yeah, Dr. Sheff?
Yeah, If you have arthritis in your knee and you already had an ACL that was damaged a long time ago or that was never reconstructed, you don't need to go through a reconstruction before your knee replacement.
That's all done.
It's done at the same time. We actually take out the anterior cruciate ligament at the same time as surgery.
You've actually sped the surgery up.
Yeah.
Okay, on this side, in the very back.
I've heard that some cases about someone who has a knee operation, sometimes the knee kind of locked. You know, they are walking. My uncle had one and my mom, but when they are walking, the knee locks, so they have to put the other foot that do not have the operation. How common is that, and what if you have to have your other knee operated and both knees locked, that you can operate and locked and you cannot?
Dr. Mason, did you hear the question? She has an uncle that had one knee fixed and it's locking.
There are two things that, one is almost, I would say, every artificial knee will click, particularly early in the post-op.
Should probably stop, I guess.
And if you move it, you can make some clicking. A locking that happens while you're moving, that's not normal, and that shouldn't be something that happens on one side, much less on both sides.
I think what you're talking about is possibly someone who has an unstable total knee, meaning it doesn't quite hold them up. And that's really a technical problem that can be solved by the surgeon at the time of initial surgery. So, what we do is we have to balance the ligaments very carefully during surgery. If that's not done, then people can experience locking. That's why it's important to have someone who's pretty experienced do your knee replacement.
So at this point, I'm going to say we're probably a little over time. I wanted to thank Dr. Mason, Dr. Fehring, Dr. Sheth, and Dr. Springer, and everybody here. And as everybody's walking out, if you have a burning question that can't wait till you see us in the office, just be sure to catch us on the way out. Thank you.